And it doesn't matter what you look at, what measure you look at, it's an indicator of poor prognosis. So, anxiety, very common, lifetime prevalence, 51% in bipolar disorder. What type of anxiety disorders? 22% OCD, 18.4% GAD, but lots with subsyndromal symptoms. So anxiety symptoms very common. How do we deal with it? There's not lots of data. What we would often think about with anxiety disorders, particularly the OCD, would be SSRIs. And we may end up being forced into a situation of using the SSRIs, possibly even at higher doses for comorbid OCD, but again, making sure we've got good anti-manic cover there. Mood stabilizers, really very unclear how much effect they have on anxiety. Valproate is a bit anxiolytic, whereas lithium I don't think is particularly anxiolytic. We may think about atypical antipsychotics. Again, you might be thinking about quetiapine, because that has anxiolytic effects. It has evidence in GAD. Pregabalin, gabapentin, I know there's lots of concerns about misuse, particularly in this part of the world with these drugs, but sometimes they can be helpful when your back is up against the wall. The key for both this and any comorbidity is try and aggressively treat the comorbidity. You will not get rid of the comorbidity just by treating the bipolar, and you will not treat the bipolar unless you get rid of the comorbidity. So make sure you do assess properly, identify comorbidities, and try and treat. Substance misuse, very, very common. Drugs, alcohol in bipolar disorder. That's American data, but I think probably across the world. And we have a problem here in that bipolar disorder makes substance use more likely, which probably makes bipolar disorder worse. How do we deal with that? Difficult. This is guidance from the BAP substance misuse guidance. And basically it says there's really not a lot of evidence. Just pick out a couple of bullet points here. These three up here. Certainly for alcohol, there is a bit of evidence for naltrexone, acamprosate, and disulfiram for patients with comorbid alcohol problems. For most other substance misuses, we're not really quite sure, but I would just go with the general principle. Treat it aggressively. Try and deal with substance misuse. And the third comorbidity is personality disorder. I think this is an important one because we're seeing this in maybe 30% of our patients. And remember that it's not necessarily an either-or diagnosis. Is it bipolar or is it personality? It can be both. And the most common one, in this study from Spain, was borderline. And rapid cycling bipolar 2 and borderline, very difficult. Go back to first principles. This is a helpful table to think about how to differentiate them. Remember, bipolar has a defined onset. There's usually, you can identify a first episode. Often depression, often in teens or 20s. Much harder with borderline. And remember that mood change is often precipitated by external events. Remember that we've got chronic impulsivity in borderline, whereas it tends to be more episodic in bipolar. Self-mutilation more common in borderline than in bipolar. This one I think is a good one. Emptiness and feelings of emptiness, very typical of borderline, but less so of bipolar. But remember, they can coexist, which just does make it complicated. So, comorbidities, basically treat the comorbidity hard, because it leads to poor prognosis. So, the final 3-4 minutes on the art of managing bipolar disorder. We need to make sure we diagnose people well. We need to use our pharmacological treatments appropriately, thinking about the science and the evidence. But I think we then need to think about the non-pharmacological strategies to help us manage our patients with bipolar disorder. And this is where, again, I think there's an awful lot of art. So I'm just going to very, very quickly run through some important elements to the artful management of bipolar disorder. First one is social rhythms. There is some evidence that social rhythm therapy can be helpful. We don't have that available. But what I do think we can encourage patients to do is have regular bedtimes and get-up times. I think that is actually really important. We have a culture in the UK where people lie in on Saturday and Sunday mornings, and I think that that can be bad. I think it can be bad if you have some nights of the week when you go to bed much later. Again, we have a culture, Friday, Saturday night, people go to bed much later. These things can really screw up your bipolar disorder. So I advise patients to go to bed at the same time every day and get up at the same time every day and try and have good quality sleep. Sleep disruption is a very, very common precipitant for disturbance of bipolar disorder. Next point, relapse signature. Patients often have characteristic symptoms that occur for them when they relapse. And if they can identify those, and you help them with some strategies they could employ if they get that, which might be start your antidepressant if you start getting low, increase your quetiapine maybe, or some PRN medication if they're not sleeping, which might be a sign they're going high. A number of different things you can do. Train them to identify their relapse signature, you get better outcomes. That is one element of psychoeducation as developed by the Barcelona group. And the Barcelona group have demonstrated that group psychotherapy, an hour and a half every week for the best part of 6 months, compared to sitting in a group talking about Barcelona football team for an hour and a half, leads to better outcomes. And that's even with Barcelona football team being pretty good and winning quite a lot. So they do have better outcomes with psychoeducation, and that is in part to do with relapse signature. If you want to know how to do it, Edward Vieta and Francis Colomb have written an excellent book that describes how to actually do the psychoed. It's much more involved than you might think. How does psychoed work? And note, they've actually got 5-year follow-up data showing benefit. How does it work? Probably by helping, or at least one of the things, is helping medication adherence. Training patients to understand the importance and significance of the illness and the importance and significance of pharmacological therapy. What we know is that adherence is not always great. Lithium, mean adherence, 72 days. And remember, if you stop lithium suddenly, you've got a 50% risk of relapse within 3 months. David Cousins will mention that a little bit in the next talk. But this is a big issue, and clearly if people are adherent and their drugs, whatever it is, remains in the therapeutic range, they have better outcomes than if they are partially adherent and they have subtherapeutic levels. And remember, adherence is not usually an all or nothing thing. It's much more common that people are partially adherent. I usually am if I'm on a course of antibiotics. I almost always have some tablets left at the end. I find this useful, the Mars Medication Adherence Rating Scale, developed for schizophrenia, but a really good, useful way of getting into a discussion about adherence with patients, which otherwise can be challenging. Are you taking my pills? Of course I am. Yeah? People can be sometimes frightened of actually saying they're not. So this can be a useful tool. You can download it from the web. 10 questions, very simple. Give it to patients to take. If there are problems with adherence, don't forget long-acting injectables. There is data for risperidone leading to better outcomes. Note there was no significant effect on depressive relapses, but risperidone did work, and there is similar data for aripiprazole depot. It's just not a nice graph, so it didn't make a nice slide. Another critical thing in terms of the holistic management of your patients is using mood diaries. Rapid cycling, I said, take 6-month perspective. How are you going to do that? Get patients to fill mood charts in. Doesn't have to be this one. I chose this one because it's colourful, makes a good slide. But there's loads of different mood charts you can download. You can just get people to write down a number each day reflecting their mood. Discuss with them the scale that they're going to use. And then when they come and see you, lay the mood charts out. Go through them. Look at the proportion of the time they've been unwell and what polarity that has been in relation to any changes in treatment. Think long term. This helps. And think about all interventions necessary. I haven't got time to go into this particular intervention, vagus nerve stimulation, but there is data for vagus nerve stimulation in treatment-resistant depression, both unipolar and bipolar, and the data for bipolar, the diamonds, the orange diamond at the top, was at least as good as the orange squares, which was unipolar disorder. And finally, I think it's really important to instill hope into our patients, because our patients can feel very nihilistic and hopeless. That is a symptom of depression, and that's the most common polarity of the disorder. And they can just feel it's all a waste of time, it's all hopeless. To the point that they won't even say to you, I think I should be doing better. Is there anything else that could be taken? So you may well need to be proactive reviewing the treatments they're on, and suggesting changes to try and help your patient get better and spend more time well. So my conclusions are, make a clear diagnosis. That is always important for any evidence-based medicine. Patients with rapid cycling need careful attention and assessment. Treat comorbidities aggressively, and think holistically. That means psychoeducation, social rhythms, relapse signatures, discussions about adherence, use of mood charts, and consideration of all available treatment options. That is applying the art to the science of the various different trials that we have available. Thank you very much for your attention.
Thank you very much for such a nice and wonderful presentation. And actually, what makes me happy is my subject is psychiatric rehabilitation. And I'm hearing from masters of psychopharmacology talking about non-pharmacological interventions.
Yeah.
So I'm really happy to hear you and hear Fiona in the morning, and Professor Osama as well. He's a psychopharmacologist on American side. So the floor is open now for 15 minutes of discussion.
So that's the art of psychopharmacology. We must never lose the art of psychopharmacology.
Thank you very much for this wonderful presentation. My name is Nasser, I'm a consultant psychiatrist. My question is, the comorbidity that you mentioned earlier, almost 40% of patients with bipolar affective disorder will suffer from other comorbidities, including an anxiety disorder.
Yeah.
And I do have a few patients who are, they suffer from an anxiety disorder, but at the same time, every time I give them something to control their anxiety, apart from the benzos, in terms of SSRIs, it seems that they overshoot straight away. And, I'm kind of struggling with them. I'm not sure where to go from there.
Yeah, exactly. It's a massive problem. There's a couple of things that I would point out. One is that we think about episodes of illness, but we also must not forget that between episodes, many patients have subsyndromal symptoms and/or comorbid symptoms. So those subsyndromal symptoms are often anxiety. I've seen many patients, they're not in an acute episode of bipolar, but they've still got the anxiety symptoms. And they can be some of the most debilitating symptoms they have. It's the things that actually prevent them getting back to work or what have you. So trying to manage them is really, really important, and we shouldn't ignore them. So you're absolutely right to try and treat them, but you're also absolutely right that they can be a devil to treat. I think some people do respond to SSRIs, and I certainly use SSRIs with somebody who's got OCD, comorbid OCD. Often I'm having to push the dose up quite a bit, but I do try and make sure that that is with really good anti-manic cover. So I think if somebody is always overshooting, okay, you've got two things to think about. Do I have to do something different than antidepressants, or do I need to give more or better anti-manic treatments as well to try and prevent that happening? And I think you have to look at your individual patients and the situation you're in. If I'm using an antidepressant as an aside, what I tend to do is use citalopram, escitalopram, or bupropion, because the risk of switching seems to be lower with those than with SNRIs or tricyclics. And I tend to go with escitalopram rather than paroxetine or fluoxetine. Fluoxetine, because if you have to stop it suddenly, it's going to take 5 weeks to wash out, big problem. But conversely, paroxetine, if you've got to stop it suddenly, you get compulsion discontinuation symptoms. Whereas citalopram or escitalopram, you can stop relatively quickly without major problems. If you can't use the SSRIs, then I think you are having to think about these other sort of options. And I think you're going to be thinking about quetiapine, given that it does have, it makes people big, but it does have specific effects on GAD. I might think about it, if they were having problems with weight gain, I might be thinking about lorazepam. There's no great evidence around lorazepam and anxiety, but I might think about lorazepam. And I guess then that's when I would also then be starting to think about pregabalin and gabapentin. So there's no magic answer, I'm afraid. But those would be the sort of things that I'd be thinking about, the various different options that I'd be thinking about. And CBT, psychological management of the anxiety as well. We mustn't forget that.
Thank you very much for the excellent talk, Ms. Kenneth. How do you differentiate mixed states from intra-year cycling, or very, very rapid cycling?
Okay. When you said how to differentiate mixed states, I thought you were going to go on and say how to distinguish that from, say, unipolar depression with agitation, which I think is another difficult thing. So let me answer my own question first, and that would be, I wouldn't diagnose bipolar disorder on the basis of mixed symptoms, unless it's very clearly mania with the odd depressive symptoms. I think that is a problem, and I think some overdiagnosis of bipolar disorder comes about by people with unipolar and agitation being diagnosed as having a mixed episode, and therefore they've got bipolar, despite the fact they've never ever clearly been elated, and therefore I feel uncomfortable about that. So how do we differentiate from that from ultradian cycling? I don't know. I'm not sure that I necessarily care that much, because I think both of them are problematic, and both of them I'm going to manage in a similar way. If you've got mixed or you've got ultradian cycling, those are definitely the patients I want to steer clear of antidepressants. I want to try and keep medication as stable as possible. For these rapid cycling patients, or certainly the ultradian, it's try and find a treatment strategy that is producing some benefit, and then try and give it several months, and try and resist the temptation for constantly changing, because that just contributes to the destabilisation of the cycling. So I'd say to patients, right, we're going to stick with this, and if you can, complete mood charts. And then what I want to do is I want to see those over the next 4, 5, 6 months, and I want to see how you're doing, and then we can review again. It's difficult, because if they've got lots of symptoms, they may well need a lot of support through that period of time as well. But I think we have a problem if we keep changing medications in response to these difficult situations, because I think we then just contribute to the problem rather than solve it.
Thank you very much. That's very helpful. Mood diaries.
Yeah.
Is there a mood diary, or is there a recommendation for how a patient would score a mixed mood?
No, I usually do it entirely on the basis of what the patient's prepared to do, however they're prepared to do it. I don't recommend any particular one. So one thing I would say is you have to be slightly careful with these mood diaries. The patient's got to be prepared to do it. Secondly, you have to be careful it doesn't make them too introspective. So for some patients, it can make them worse, and that's a big problem for those patients. But if you're not getting into the situation of introspection, or too much into introspection, and you can get people just to rate their mood once a day, and it's the first thing that comes into their mind, don't think about it too much. Different patients score it in different ways. Some will score 0 to 10, 5 being euthymia, 10 being manic, 0 being depressed. Others will say 0 is euthymia, -5 is depressed, +5 is whatever. And for the people with mixed, what we'll sometimes do is graph it, but what they'll do is they'll have 2 bars. So that they'll have a bar for depression and a bar for mania. So you can see how mixed they are. In the one I showed you, you've got red and blue, and you allow people to go in both directions. So they can go +3, but also -2. So that's the other way of getting mixed symptoms. I don't care how it's done. You just need to agree it with the patient.
So do you psychoeducate them about mixed symptoms?
Yeah.
I do as well.
Yeah. I think that has to be part of the psychology.
Thank you very much.
Thank you very much for the wonderful presentation. I'll try to make my question, which is actually make it short. It's not a question, it's about the case, basically. I've been struggling, I'm sure many colleagues from the same hospital, one case of unremittent mania for the last 6 or 7 years. And the maximum time was 1 to 2 weeks. I tried 1, 2, and 3 antipsychotics in addition up to clozapine.
And
clozapine, 1, 2, or 3 antimanics together or individuals. He can come down only if he is to the extent of being intoxicated with medication, starts to be confused, is 52. Once you reduce the medication, he flares up straight away. Try ECT, work it 2 weeks later, relapse. Try maintenance ECT, and when you get to the extent of weekly ECT, hold him.
Okay. Weekly
hold him. Yeah. But we found some practical difficulties to continue on that.
Okay.
I'm just thinking, I was going back to the conventional antipsychotics. one of my colleagues advised me, I put him on haloperidol,
Yeah.
a single medication,
Yeah.
push the dose up to 70 milligrams.
Yeah.
Acute symptoms started to go up, and then I'm really scared.
Yeah.
Then I'm now trying again with risperidone, push it up.
Yeah.
To be honest, I just failed basically.
Yeah.
Then you're saying, yeah, on that plan it can save this guy?
Okay, so what I said was that treatment-resistant mania is relatively rare. The problem is that when it does occur, it is a nightmare. So I have seen one or two patients, as the patient you described, and they are a massive, massive challenge. And I'm not sure that I've got anything particularly to add to what you've already suggested. I think that the maintenance ECT is something that sometimes we end up doing. What I really don't know, and I'm intrigued, and I'm not recommending it, but there's thoughts going through my mind. Vagus nerve stimulation has been shown to be effective in depression.
Which center?
It's not being...
Which center in the UK?
Well, we do
Don't have
it.
it here.
We do it.
I'm sending him over.
We might not necessarily thank you necessarily as this patient, but the thing is we do not know whether VNS works in mania, but what we do, there is some evidence, a small case series, that patients on maintenance ECT, be it unipolar or bipolar patients, seem to, a lot of them, about 3/4 of them, no longer needed maintenance ECT after having VNS. Now, I have never used VNS for mania. I've never even recommended it for using it in mania, but I do just wonder. I think a less aggressive treatment that might also be worthwhile exploring if you have it available would be TMS, transcranial magnetic stimulation.
We do have it, but I haven't started to use it yet. We do have it in Abu Dhabi.
Well, I think it might just be worthwhile looking at. I mean, my guess is it won't work, but it does have many advantages over giving this guy ECT on a weekly basis.
If we ended up giving the weekly ECT and he's okay with that, do you think this would be a lifetime?
It may be. But I don't, I mean, okay, but let me just throw that in a different way, okay? Maintenance ECT is something we try and avoid doing. We just try and avoid doing it. But if we do get into maintenance ECT, I never say to a patient, we're going to have to do this for life. I never say to a patient, you're going to have to take lithium for the rest of your life. Because I cannot predict what's going to happen in 5 or 10 years' time. There may be some genetic cure for bipolar disorder in 10 years' time. I don't know. There may be some other treatment. So I would never say for life. What I would say is, for the foreseeable future, we're going to need to keep doing it, and I would say the same about that. So if the maintenance CCT is working, then I'd say do that for the foreseeable future, but also think about what other sort of options there might be, and every now and again, maybe explore whether one of these other options might
There
help.
was something called tryptophan depletion.
Well, tryptophan depletion can lead to a lowered mood, but it seems to lead to a lower mood in people who are responding to a serotonergic antidepressant. So I hope he's not an antidepressant.
Before, never been depressed before.
So
I want to say
it's a
that
big, it's a big challenge.
depressed, but
It's a big challenge.
never been depressed.
I'm sorry, I haven't got a miracle here.
Thank you very much. Thank you. Sorry for a long question.
Thank you very much, Professor Hamish, for such wonderful discussion, even, and thanks for all colleagues for sharing this experience. Dr. Osama, you'd like?
I just want to also extend my appreciation for Professor McAllister Williams, because you are a true artist. You are able to present a lot of scientific information, some meta-analysis, and good science, but you also recognize the effectiveness and the individual experience, and even the small number of studies that can be very indicative, especially the Tom Muir study and our post studies. And I've seen those patients personally on 4 West at the NIH Medical Center before 87. So you're being able to recognize these studies are valuable and demonstrative is really unique. And I really would like to thank you so much for this wonderful presentation. We are two artists again, and we are very proud of having you today.
Thank you very much.
Thank you very much for the discussion. What we'll be having certificate given in the morning. So we'll be having the comment section. Actually, the earlier you come, the earlier we'll finish. So please don't be late for the comment session. Thank you very much. Thank you.